So am gonna I am a social epidemiologist, which means I look at how diseases are unequally distributed through populations. And I'm a quantitative researcher eh, for the most part. And I don't really specialize in health communication, but I am stretching a little bit for the purpose of this presentation, and hopefully it connects. Um, and I don't have the most in-depth knowledge of what's been happening in the UK in terms of COVID-19 and how y'all have been handling it there. I've been following it, but not all that closely to be able to make fine-grained comparisons, and maybe that will come up in conversation afterwards. But in just my unprofessional view, the big differences with relevance to COVID and to my talk are the healthcare systems. Obviously, the US does not have universal national healthcare or even national health insurance. We have a lot of people uninsured or who have insurance but still can't afford care for various reasons, or are unable to access care because there's a largely for-profit system that may not be serving them geographically, culturally, etc. Another major difference is the use of what we call NPIs, or non-pharmaceutical interventions. That's what I really mean here is there's a variety of measures, but I'm really thinking about what some people are calling lockdowns, or I think a term used in the UK was shielding. We don't really have the concept of shielding in the US. There have been certain states and certain county governments that have, for relatively brief periods of time, issued stay-at-home orders, closure of certain non-essential businesses. But when that's happened, it's been much more lax than in the UK or many other countries. It's been limited to particular geographic areas. It has been time limited, and it has largely not returned, including in our latest wave of COVID infections over the November, December time period, and decreasing to the present day. And then with especially relevant to what I'm going to talk about are the societies. UK versus US have pretty different understandings of race and class. And I won't go too in depth into that, but even in terms of what we call these things, I think UK tends to call it ethnicity rather than race. Ethnicity means something a little bit different. Here in the US, we say people of color. You may say Black and minority ethnic. There have been powerful social movements against racism in the US that have made race at least part of the discussion and consciousness in a way that I think is less salient in the UK. But we tend not to talk about economic class in the US, and for a long time sort of pretended that it didn't exist. And in the last few years, that's changed a little bit, but we often just kind of ignore it, and particularly don't talk about how race and class intersect and interact with one another. But I'll be touching on that just a bit in the coming slides. So we've not been doing a great job of managing the COVID-19 pandemic. This should be no surprise in the US. We've had over 500,000 confirmed deaths. There is some undercounting, so it's probably a bit higher than the official death toll at this point. We don't have great data on this. Speculation, a quarter or a third of the population has been infected in the US with SARS-CoV-2 at least once. And then there's a lot of uncertainty about where we go from here. The US media and US sort of prominent public health figures, I think, are pretty optimistic right now because the numbers are decreasing in terms of deaths and cases and hospitalizations. And we have beginnings of a vaccination campaign that's going a bit faster than first expected. The unknowns are what happens with the new variants. We have the B.1.17 circulating quite widely in the US, which is more infectious and more likely to kill people. And and how long does the vaccination last, who's going to ultimately refuse to get it, and what's going to happen as restrictions continue to be relaxed. So states like Texas are basically declaring their, if not the pandemic over, then their efforts to control the pandemic over, to the extent that they ever existed, by saying no more requirements to wear masks, no more restrictions on business whatsoever, and this is pretty concerning. So just a matter of time to see what happens from here. But what I'm really going to focus on here is comparing the unequal toll of the pandemic in the US by race and by class, and the causes behind these inequalities, taking that and comparing it to the public response, which has been largely individualistic and largely ignoring the causes of inequalities. This is a graph that I made using data from CDC, the main federal public health agency in the US. This is men and boys ages birth to 60 years old. And what's being plotted here are mortality curves by age. So what, at each age, what proportion of the population has died of COVID-19? So the scale is like 200 deaths per 100,000 all the way up to 600 deaths per 100,000, broken out by race. And you can see the blue line on the top, just absolutely astronomical rates among the Native Hawaiian and Pacific Islander communities. So these are Native Hawaiians, Samoans, Marshall Islanders, a lot of people who were displaced from US imperialism and US nuclear testing in the South Pacific to either Hawaii or the US continent. Also pretty high American Indian populations, Latino populations who are largely immigrants or descendants of immigrants from Mexico and Central America, and Black people. So these are all these groups are dying at far higher rates than the sort of magenta line at the bottom, which is white men. You would see a pretty similar pattern if I looked at women. It's just a bit more extreme for the men. So I'm showing you because it's hard to look at these figures on small slides. And if you extend it out to later ages, you basically have a situation where if you are white and under the age of, say, 50, there's an extremely low chance of dying from COVID-19. And if you are in another racial ethnic group and at a younger age, there is quite a bit higher rate. So we're really living through different pandemics with different stakes, different death tolls. And the question always comes up sort of like, is it race? Is it class? Is it both? And it's basically always both. This may be a bit harder to parse. There's a lot going on in this plot. But the red bars are death rates for men. The blue bars are death rates for women. And then it's broken down by racial group. And then within each racial group, it's comparing educational attainment for people who died ages 25 and older. So the takeaways here are, one, you can see what we saw on the earlier slide, just astronomically high rates among the Pacific Islanders and American Indian populations. You can also see within each racial group, those with the lowest education are dying at the highest rates. And those with the highest education dying at the lowest rates. And then you can compare across groups. So you can say that white men with the lowest level of education are dying at the same rate as Black and Latino men with the highest education. So if you have a college degree and you're dying at the same rate as white people with a high school degree or less. So there's both race and class inequalities going on at the same time. And what's driving these differences? So differences in mortality rates. So you can kind of think about two different categories. There's difference in exposure to the virus itself, and there's differences in what happens to you once you're infected. What happens once you're infected largely is going to be a result of comorbidities. So do you have diabetes or other health issues that are more likely to lead to death once you have COVID-19? And also we have these big gaps in healthcare access in the US. Are you insured? Are you comfortable using the healthcare system? Can you get high quality healthcare in the place that you would go to? And these inequalities are much bigger compared to another country that had true universal healthcare, for instance. And then what I'm more focused on is differences in exposure. So you have, varying by class and race, a lot of differences in housing. If you live in crowded housing where you have more people per room, you're more likely to be infected once somebody has COVID in your household. And if you have what we call multi-generational housing, where older and younger generations live together, you have a pretty high risk situation because you have younger people going out, perhaps getting infected at work, coming home and exposing older people who are more likely to get very sick and die. And then you have differences in workplace. We've had a lot of, and I'll be talking about this more later, there are high-risk workplaces. There are lots of people getting infected in their workplaces. And some workplaces are safer than others. Some people are able to work from home, others cannot. Some people are working in person in places where there's good infection control practices, and others are not. And that is patterned strongly by both race and class in the US. And this is just, I looked at census data. This was, I gave a talk early in the pandemic when in the US, it was largely hitting New York City where I was living at the time. And we have just tremendous differences in housing by race. And this is both current reasons and historical reasons, patterns of residential segregation, denying Black people home loans, and generational wealth. So in the US, at least, wealth is largely passed on within families and much of it tied up in housing. So these are some big gaps. You have, if you're Black or Latinx, you are, and a senior, 65 or older, you're twice as likely to be living with younger generations than a white person. So this can explain, I think, quite a big part of the racial gaps we're seeing. Then when I first started doing this work, even just a couple of months ago, there's very little data on occupational risk of COVID infection, and more is starting to come in, but it's still not all that much. For instance, last I checked, there's only one study in all of the US on risk of infection among grocery store workers. In Boston, actually, that's where they did antibody testing in a large grocery store and found that grocery store workers were much more likely to have been infected and have antibodies than people in the communities they came from. And if they were in customer-facing roles, they were like 5 times more likely than their coworkers in other roles that were not customer-facing. So you have this big occupational exposure pathway happening that's not being researched enough, and it's not being, as you'll see later, acknowledged by government or public health authorities. This is from a recent study looking at data in California, showing excess mortality rates at different occupations, ages 18 to 65. So that's saying, compared to a normal year, at what rate are people in these occupations dying this year during the pandemic? A lot of these deaths are attributable to COVID-19. And you have cooks dying at the highest excess mortality rate, 60% excess deaths. You have people working in factories, in construction, all dying at pretty high rates. And these are largely jobs that are done by people of color in the US and by immigrant populations. And meatpacking plants have been drawn, at least early in the pandemic, drew a lot of attention in US media, where these are large plants and they employ thousands of workers processing chicken and beef and pork. And it's a largely immigrant worker population. They weren't given masks or other ventilation, other protective measures. And there were a lot of deaths and a lot of infections that seeded the virus in surrounding communities. This is just one news story about particularly egregious case where Tyson, one of the major food companies that does meat processing, there were managers placing bets on how many workers would get COVID, and there's a lawsuit against them now. So just like making light, not just making light, but kind of having fun with the fact that they're putting workers in these high risk situations where they could die or their household members could die. So the conditions that allow the coronavirus to spread in meatpacking plants are not all that different from the conditions that allow it to spread in a kitchen at a restaurant, for example, or a factory, or many different settings where you have workers working quite close to one another and in poorly ventilated settings. So meatpacking plants got attention because they're quite large and they also threatened the US meat supply. But there is evidence that this widespread infection is happening in all sorts of workplaces. So we have a US agency in charge of occupational health and safety called OSHA. It was created in 1970. It's been pretty underfunded since the beginning, but especially now. They have really limited enforcement powers. There's only a few thousand inspectors to cover millions of workplaces in the entire country. The maximum fine they give is maybe $100,000, which usually gets to lower than that once they challenge the fine. And many businesses find that it's just easier to pay the fine or argue the fine than to make improvements. And then you combine that with the Trump administration failing to implement a COVID-specific worker protection regulation. So then there was no specific law that they could enforce. They could try to rely on what's called the general duty clause, which is like vaguely stating that employers have a general duty to maintain a workplace free of hazards. But that is a pretty weak mechanism. And then you can see here, this is from the Wall Street Journal, that between 2019 and 2020, there was a big increase in complaints to OSHA by workers, but a decrease in inspections. And most of this increase was COVID, related to COVID concerns. And so if they do come for an inspection, that's pretty rare. Maybe there will be improvements, but maybe there won't be. And then I'm going to transition to from what I was just talking about, so the sort of structural causes of COVID and COVID inequities patterned by race and class, to what we've been hearing from governors, but also other politicians and public health officials, which is this rhetoric of individual blaming. And not just blaming, but embedding the blaming in their explanation of how coronavirus spreads. So in the US and in most societies where COVID is widespread, we don't know what percent is spreading in particular workplaces versus restaurants versus homes. We just don't have the public health surveillance capability to answer those questions clearly. But amidst this uncertainty, you have governors saying things like, most of the spread we're seeing cannot be traced to restaurants or small businesses. Most of it traces to small gatherings of family and friends. And then this is the Arizona governor talking in, I think, early December about where COVID spreads, and saying this as a pretext for relaxing restrictions on businesses, because he's claiming COVID's not spreading at businesses. Different state, Rhode Island Governor Gina Raimondo, who is now the US Secretary of Commerce, but at the time she was still governor. She has a similar explanation. We know spread is happening in these casual social settings, but not in larger, more structured environments. And she goes on to say that she's referring to workplaces, offices, schools, transportation, also as pretext for not implementing stronger regulation or non-essential business closure. In my state of Massachusetts, you have Governor Charlie Baker saying the same thing. Work in many cases is not where where spread develops because people at work are abiding by rules and guidance. So this is simply not true. There's poorly ventilated workplaces. Coronavirus is spread through droplets, but also aerosols. So even if you have a mask, there continues to be risk, especially if you're spending 40 or more hours a week in an enclosed space with other workers. And he's also saying, again, informal gatherings, social gatherings. And I really want to emphasize Andrew Cuomo, the New York governor, who is now quite recently in quite a bit of trouble politically for various reasons, but some of it has to do with covering up deaths in or undercounting deaths in care homes under his watch. So that he initiated a campaign against what he called living room spread. And the idea here is that he claims 74% of COVID cases are attributable to spread that's happening in a category he's calling household/social gatherings. And then it's quite small in these other settings. So sports is only 1%, restaurants are only 1.4%. So what is he doing here? One, he's combining households and social gatherings. These are actually two quite different categories. So household clusters happen when people living together spread in their home among themselves. And it's seen as basically unavoidable. There haven't been programs in the US really to remove people from homes when someone is infected. And roughly 1 in 7 people who lives with someone with COVID will themselves get infected. So we do know that a lot of spread is happening within households. Social gatherings is a completely distinct category. That means people from different households are meeting up, and that's where the spread is happening. Maybe they're having dinner together, drinking together, having a party, whatever. In other states where we have contact tracing data, social gatherings account for something like 1% of identified clusters. And in a moment, I'll talk about how the limitations of the data. But he's basically combining two categories: household spread, which is probably something like 71%, and social gatherings, which is maybe 2%, and saying they're the same thing, and then creating an advertising campaign that's really painting the problem as social gatherings. So whereas all the other governors weren't really citing specific data, this message does cite specific data, but in a highly misleading way, even if you ignore the inadequacy of contact tracing data. And to get into the contact tracing data, so data is political. Health data reflects both biological processes and social processes that lead to the underlying disease that's happening and its dynamics, but also the ways that we are able to collect data. And I highlight here a story from the state of Arkansas, where a restaurant owner had a large cluster among its workers of infections and reported it to the state. And the state called up some of them, didn't call up others, and ultimately did not put the restaurant's outbreak in its biweekly reports of coronavirus clusters for whatever reason. And it didn't put any restaurant in its reports ever, in fact, and was just systematically undercounting clusters, even the ones that came to its attention. And I'm not quite sure why that is. There are particular rules for how many cases reported over what time period, how many had direct contact with the contact tracers. And I also wouldn't take out of the question the idea that pressure by industry associations would have them systematically not report clusters in certain industries, because if it seems like clusters are happening in restaurants, people will not want to eat at restaurants. And this is an unusual case because the owner of the restaurant cared enough to go to media about it. But I think the norm is that clusters routinely don't get identified and nobody ever knows about it. So contact tracing is really not, it's not about trying to understand how disease spreads and where. It's really a public health intervention that is supposed to isolate close contacts of people who are infected to prevent them from further infecting more people. Secondarily, it's being used to try to understand the dynamics of how and where COVID spreads. And there's some serious limitations when trying to use it for this latter purpose. In all countries, basically, where COVID's widespread at least, only a very small fraction of infections are confirmed through testing. Most people don't seek testing either because they have an asymptomatic case or a mild case, or just think they know they have it, so what's the point of getting tested? So people who are likely to get tested, they tend to have the most healthcare access. This is my hypothesis. There's not actually research on this yet for healthcare access and testing. So people in the US, at least, if you're white, if you're better off, you're more likely to get tested once infected. If you're a person of color, if you're working class, you're probably less likely to get tested. So this has the effect of understating the testing data, understating inequalities. And then you have the question of disease severity. If you have a less severe case, you're probably not going to get tested, especially if you don't have symptoms and know you have anything to worry about in the first place. And here we do have some research showing that in some cases, let's say half or a little more than half of older people, say 70 or above, are getting their infections confirmed through testing. But for younger people, if you're a child or in your early 20s, it's only something like 10 or 20% who are infected who are having their cases confirmed through testing. Many, many of them are asymptomatic or perhaps have what feels like a cold. So contact tracing happens based on known testing. So we have a small minority of infections ended up tested, and then only a small minority of those will end up contact traced to a particular source. And you have to cooperate with government to participate in the contact tracing. In the US, we have very low participation rate in contact tracing, less than half in some states. And then it's a question of how easy it is to conduct the contact tracing. If you're living in a care home, for instance, there's somebody responsible for you. There's, you know where everyone in the care home is because they all live there and they're all quite severe. So it's easier to keep track of care home infections and deaths. If you're a customer at a restaurant, in the vast majority of cases, nobody is taking your address or phone number or email address. So if you end up with an infection after doing indoor dining, you're not going to know if you got it there or somewhere else. And nobody in government is going to be able to connect the dots because there's simply no data out there that would allow them to do so. If you're a worker, it's a bit easier, but that requires, in many cases, the employer to cooperate with authorities, which in some instances doesn't happen. And workers also in high-risk industries tend to be younger, so may not be getting severely ill, so may not be tested in the first place. Nevertheless, you have contact tracing data being used to argue that certain settings, workplaces, schools, etc., are safe and there's not much spread happening there. This is a typical case that we're seeing all over the country. So this is one county in the state of Michigan where the Restaurant Association sued the government for lost business, and in other cases it's just against having any restrictions. So in their lawsuit, they're citing contact tracing data, which shows that just 4.4% of COVID-19 infections came from restaurants in the state and only 2% nationally. So one, we don't know, is 4% a lot? I think it kind of does sound like a lot, especially if you consider that probably at least half are happening within people's households. And then again, there's the inadequacies of contact tracing data. They're using this data produced by these social processes to argue against restrictions when it really doesn't support that because of all these limitations. And I'll just to kind of wrap this up. In general, in epidemiology and public health, there have been individualistic ideologies behind understanding how disease spread and what to do to stop the spread of disease. And Nancy Krieger, who is a well-known social epidemiologist, came up with these ideas, just naming the fact that there are these theories underlying epidemiologic research and public health in general. And some of them are very much focused on individuals and not on societies. So she coined the phrase lifestyle theories and biomedical theories of disease distribution. And lifestyle theory says that the reason why diseases are distributed across societies in the way they are is because some people have freely chosen behaviors that put them at greater risk or lesser risk. And biomedical theory attributes differences in disease distribution to innate, essential biological differences, like genetic differences in disease susceptibility, for instance. And each of these sort of anticipates individually based interventions. So is it going to be vaccination and medical treatment? That's what would follow this biomedical worldview. But also not really considering the factors that would allow people to get vaccinated. We have a lot of social inequality in vaccination rates already in the US. Not really considering the fact that we don't have truly universal healthcare in the US. And then it's also lifestyle theory is anticipating interventions that are just calling for more personal responsibility. We have new variants in the US. What's the solution? Wear 2 masks. Is the government going to give you masks? No. Is the government going to shut down high-risk, non-essential businesses and pay workers to stay home? No, we've largely given up on that in the US to the extent that we tried it at all. And these are longstanding. If you can think about public health before COVID, there was so much emphasis, I'm guessing in the UK, but particularly in the US, around diet and exercise and the sort of freely chosen, quote unquote, freely chosen health behaviors that people can use to minimize their risk of death, and not really paying attention to why people are able to have healthier diets, for instance, or to get exercise in their personal life. So what is the purpose of individualizing risk in the way that we do? For COVID-19, I think there's a few things at play. So we did have a large bill for coronavirus relief early in the pandemic. I think it passed in March of 2020. Spent, I think, over $1 trillion on increasing unemployment benefits, subsidizing businesses that had to close or otherwise lost money in the crisis. And this allowed certain states to implement strong public health measures while imperfect, businesses could shut and still stay afloat, and workers could file for unemployment. And actually the unemployment subsidy was so large that 3/4 of those receiving unemployment were making more than they had on the job. And that money ran out within a few months, and we don't have another coronavirus relief package coming until perhaps the coming weeks. And it's not really focused on allowing for stronger public health non-pharmaceutical interventions. It's more focused on just giving people money and vaccines. And I think the reason the US has handled the crisis in the way it has, where risk is really individualized and government has such a small role in preventing people's exposure, is that people are doing, if you're someone who's privileged in the US political system, if you're wealthy, if you're white, your risk of infection and your risk of subsequent death after infection are pretty low. And the stock market is doing well, and real estate market is doing well. A lot of people are economically better off right now, not just billionaires, but a lot of middle class people are better off now than they were before the pandemic began. And the people who tend not to matter in the US political system, they're the ones who are bearing the brunt of the pandemic and of the economic fallout of the pandemic. So I think the question of who has power and who is being harmed are really central to understanding why managing the pandemic has gone the way it has. And we just, there's real reluctance to regulate business. And hopefully in the coming weeks, we expect to see, or at least the Biden administration has promised, a regulation at OSHA that would protect some workers from COVID-19, but it's not clear what that will entail. It's not clear how well that will be enforced because there's so many limitations on OSHA. And we've kind of seen even the Biden administration more or less giving up on implementing stronger non-pharmaceutical interventions. They've only gone so far as to sort of complain when state governors, like in Texas or some other states, have decided to roll back their non-pharmaceutical interventions. So I will stop it at that.